Hi, thank you for joining today's lecture. I'm Joanna Chen, one of the Sinai faculty working both in patient and outpatient palliative care. And today we're going to talk about medical cannabis and review the evidence. No disclosures. The objectives of today will be first to talk about the physiology of cannabinoids and its role in therapeutics. I'm going to really do a deeper dive into the evidence regarding medical cannabis for symptom management, especially regarding the palliative care population, and then talk specifically about some of the legal considerations that impact how we practice when we talk to patients about medical cannabis. I think this is particularly relevant as we're increasingly seeing cannabis products out there, whether recreationally or medically, and a lot of patients will come to us and ask about it. Some will say that, this is potentially more natural, it will help with all these symptoms, it may help cancer. It was important for us to be informed about what the evidence actually shows. There's a lot out there in terms of cannabis in policy, in society, but our focus today will really be in the medical setting. So we'll start off with talking about some of the physiology of it and how this impacts its use in medicine. In terms of the endocannabinoid system, so our body naturally has receptors, both CB1 and CB2, throughout various areas of the body, both the skeletal system and the organs, that actually have receptors for endocannabinoids, so natural cannabis molecules that regulate a lot of the pathways regulating physiology. Exogenous cannabinoids are the ones that are derived from the cannabis plants, and the major ones being THC and CBD, but there are many, many hundreds of more cannabinoids from the whole plant derivatives that are still being studied in terms of whether isolated molecules versus more of an entourage effect of the combination have more of a therapeutic value. And when these are ingested, inhaled into the body, they also act on the receptors and therefore have a role in modulating various pathways that both impact the side effects that can be experienced as well as potential therapeutic outcomes. One of the major ways it acts in the body actually is in the cardiovascular system. It is known to impact heart rate, so it can cause tachycardia, but also in some bradycardia, as well as arrhythmias, as well as blood pressure, so it could potentially lower that. It does have more of a risk for patients with known active heart disease, especially cardiovascular angina. So anyone with recent myocardial infarctions, these cannabis use may be of a higher risk. And it similarly impacts people in terms of a risk of having stroke. Some of the big side effects are in the psychological and cognitive areas. In terms of mental health disorders, mainly it's been shown that cannabis has more of an effect on the positive psychiatric symptoms, things like psychosis, hallucinations, paranoia. So anyone with either a personal history of schizophrenia or a close relative and have a high risk of developing schizophrenia, it may be more of a risk for them to use cannabis products because it can induce some of these positive psychiatric symptoms that can be extremely uncomfortable and dangerous. Similarly for manic episodes in someone with either a history of a risk of bipolar disorder. There's less known about whether it causes specific effects on depression, but these are things definitely to keep in mind if someone has either a risk or a personal history of a psychiatric disorder. And similarly, its effects in the central nervous system, being that it acts on the reward system. I think this is a way in which it plays a role in terms of addiction and misuse, so something to definitely keep in mind. Excuse me. It also is known to have some anti-anxiety effect, which could be beneficial, and a lot of the reason that many people will say they have benefit from cannabis. So something to keep in mind, but balancing these side effects. So now we'll do a deeper dive in terms of the current evidence for medical cannabis. I think overall, the big things to take away is that most of these studies will show some improvement in the majority of symptoms relevant to palliative care. There are also a lot of reported risk of dose-dependent adverse effects, so keeping those in mind. I think, unfortunately, the major takeaway is that most of these studies are of very varied and likely poor and low quality studies. So how much can you really take these takeaways from those and apply it to your practice? And overall, there's just an insufficient amount of evidence for any strong clinical recommendations. So looking at just a general systematic review, this was done actually a few years ago already in 2015, looking at the role of cannabis generally for medicine. It's studied in various conditions, not just for cancer. It's looked at for HIV/AIDS, a lot of neurologic disorders. And the study outcomes were really kind of disease-specific outcomes, how it affects activities of daily living, and whether there were adverse effects. This systematic review looked at 79 studies. Most showed some symptom improvement, and many were not statistically significant. In terms of chronic pain, it found that there was just a moderate quality of evidence and low quality of evidence to support its use in chemo-induced nausea and vomiting. It could not find any conclusions on long-term effects of these adverse effects of using cannabinoids. So that's one thing that's unknown, is the long-term effects if people are using cannabinoids in a medical setting. What was very helpful was its summarization of the potential adverse effects. And a lot of these are in the realm of cognitive findings, which are not insignificant for some of the more frail or elderly populations that we take care of in the palliative care setting. Some of these major ones that were found were things like confusion, dizziness, somnolence. So these are not insignificant, especially when you're potentially using other medicines that may have these side effects for symptom management. It can cause things like hallucination, which is where it's impactful for patients with a history of schizophrenia. For some, it can cause actually paradoxically more nausea. So things to really think about and consider in your patients. Specifically for its use in chronic pain broadly, not just cancer pain, but chronic pain broadly, there's been various systematic reviews over the years. This one in 2017 looked at 27 studies, so again, small numbers of studies. Again, limitations is that they were not rigorous trials. A lot of the formulations are very variable. Overall, they found low strength evidence that cannabis helps with pain. Insufficient evidence in other pain populations, and some of those more significant side effects are the cognitive side effects and actually increasing risk of motor vehicle accidents if people are using that and operating vehicles. So there's risk for its actual use in society in that way if counseling is not done. In a more updated systematic review in 2021, tried to look at a similar outcome. 36 studies were included, but again, the conclusions were pretty much the same. There's not been a significant change in the conclusion of studies, despite a few more years, of whether they really show strong evidence for use in pain overall. Now, looking specifically more in the palliative care population, there's definitely, with increasing interest in studies, a lot more research done looking at the palliative care population and its use in symptom management of things like cancer pain, neuropathic pain, nausea, anorexia. More people are trying to look at its role specifically in geriatric populations. And I think even more recently, people are trying to study whether there are any interactions with cancer-directed therapies itself. So these are major implications if we're considering using cannabis for the palliative care population. Overall, though, there's still a lack of high-quality studies overall. Doppin in 2022 did a systematic review for the palliative care population. They basically looked at all available literature from 1960 to 2021. They searched for medical cannabis and in association with palliative care or advanced illness populations. They looked at the disease-specific outcomes of pain, nausea, vomiting, appetite, sleep, fatigue, and that in cancer, and then also looked at appetite and agitation and dementia, as well as appetite in the AIDS population, and then also tried to assess for adverse effects in the data. There were 52 studies that were included. Less than half were randomized controlled trials. It was a large population collectively, over 4,000 patients. Majority of them were cancer patients, only a very small number with dementia, and a small number with AIDS. Overall, again, quality of evidence very low or low for all the studies. They could not do a meta-analysis because of the wide heterogeneity of the cannabis products talked about in each study, and that's actually a common problem. Is there's so many products out there, so can one draw any conclusion about any one specific product? There were some statistically significant positive effects for some of these products, but not in large numbers. And across the studies they looked at, there were some conflicting results, actually. They found that adverse effects were reported for both cannabis and placebos in the studies they looked at, but it was also very variable in how each study reported their adverse effects. So couldn't make a general takeaway from that. And again, a major thing that was hard to decipher from the studies was whether there were any risks of drug interactions, which is important in our clinical practice. Looking specifically at the role for cancer pain, again, various systematic reviews over the years. 2017, this one of 8 RCTs, small number again, looked at, again, very different cannabinoid preparations in each study. They found that these studies had very varying quality and even methodological flaws. They found some analgesic effect, but not all of them were statistically significant. And again, dose-limiting adverse effects were found. This Cochrane systematic review in 2023, again, similar types of findings, no major updates. If you want to look at one study that tried to show a positive benefit of cannabis in cancer pain itself, this was a 2023 study of a Quebec cannabis registry. So it's just one prospective observational study. It did have significant dropouts, so risk of bias. There were over 300 cancer patients, and they looked at the patients over 3.5 years. They found statistically significant decreases in the ESAS pain scores at 3, 6, and 9-month follow-ups compared to the initial baseline score. But overall, the average scores were quite low in terms of pain. And looking over those 3, 6, and 9-month periods, they didn't find significant changes in those time periods over time cannabis was used. This study tends to have found that a balanced THC to CBD ratio strain seemed to be associated with better pain relief. They also tried to look at whether there was an impact on opioid requirements for these patients at similarly 3, 6, and 9-month follow-ups compared to baseline. They found that for low percentages of their patient population studied that there was a slight decrease in the opioid requirements, but these are small proportion of the patients they actually looked at. And they found that very low percentage of the patients had significant adverse effects, most of which were somnolence, dizziness, and fatigue. So this is just one observation study. You can't really pull causation from this. So how you use data that is available out there to guide your practice, I think, is something we have to carefully consider. One of these questions about the role of cannabis for mitigating some of the risks of opioids in the patients that we take care of has been a big question asked, especially in the light of the opioid epidemic. Again, some of these smaller studies, just like the one we talked about, try to demonstrate whether the availability and the use of medical cannabis helps to lower the requirements of opioids, but it's unclear whether those are statistically significant findings because most of the studies have been very small. This one in 2023 looked at 83 patients. It was a retrospective study. They tried to look at the change in the daily morphine equivalent requirements from baseline to an 84-day follow-up. They found that in the opioid monotherapy group alone, compared to those with using opioid and cannabis, both groups had an increase in the morphine equivalent requirements over time, but the increase was less for those who also were using cannabis. But their study was actually not powered to detect any statistically significant difference. So you can conclude for sure that it is because the cannabis was also available that they were not requiring higher doses of opioids. So unable to make any strong conclusions. From a more population-based study looking at, policies, I think there are those who try to, show whether having legalized cannabis in medicine helps the overall opioid epidemic and mortality. This study in 2018 looked at states Medicaid and also medical and adult use cannabis laws. They found that there was a very small percentage, like 5 to 6% lower, opioid prescribing in these states that had medical cannabis laws. Whether that's significant or really a causation, it's hard to know. More interestingly, there were studies that tried to demonstrate that legalization of medical cannabis may have helped decrease opioid overdose mortality over the years. There are prior studies that looked at, data from over a decade ago. This one study in 2019 extended the prior studies through 2017, and they actually found that there was a reverse in the mortality rate. So there was a higher mortality rate for states that had medical cannabis laws. But again, I think because it's so variable, they are saying you're unable to really make a strong conclusion or causation that these are actually related. Might have been just a spurious finding, and caution in drawing any causal conclusions at this time due to the lack of strong data. Now, in terms of cannabis for neuropathic pain, this 2018 study it's a Cochrane review, looked at 16 studies. Again, they showed that the medications may have increased the people achieving a 50% or higher pain relief, neuropathic pain relief compared to placebo, but it does not look like the findings were statistically significant, and study quality was not high. They did find that overall, looking at all the cannabis products together compared to placebo, there were slightly increased side effects of things like sleepiness, dizziness, and confusion, which is similarly to other findings in other studies. In terms of cannabinoids for chemo-induced nausea, again, some various systematic reviews. This one in 2016 looked at only 6 studies, variable formulations. They found that there was moderate quality evidence for cannabinoids compared to placebo and conventional antiemetics, and moderate quality evidence that showed that cannabinoids is actually less tolerated and less safe than placebo and conventional antiemetics. And they could not conclude a recommendation for recommending cannabinoids as a first or second line for chemo-induced nausea vomiting. The most recent ASCO guidelines in 2020 for chemo-induced nausea vomiting just also echoes that the evidence is insufficient to recommend using medical cannabis for preventing nausea vomiting in chemo or radiation therapy. And they also couldn't make recommendations regarding the use of these widely available cannabis products versus the few FDA-approved cannabinoid products that we will talk about in a little bit for nausea vomiting related to therapy. In terms of anorexia, cachexia, low appetite, which is a very common problem, and a major reason that patients may ask for cannabis certifications, most of the studies were actually in the HIV/AIDS population, some in cancer. This one review in 2016 looked at the cannabinoid products that are approved, so dronabinol and nabilone, versus other conventional appetite stimulants like progesterone and placebo. In HIV, dronabinol had been found to increase appetite somewhat and lead to maintaining or increasing weight, and as we'll talk about in a second, dronabinol is approved for that indication. In cancer, it's less clear. Dronabinol seemed to be less effective than progesterone or the combination, and they show no major differences in terms of outcomes between THC and CBD. One of the more newer questions out there and studies are cannabis and its role in the immune system. I think it's kind of been seen that cannabis has a role in anti-inflammatory effects, which can be important in symptom management, but there are implications for cancer-directed treatment. Some of these more recent studies, the first one in 2023, tried to look at the role of we know that there's a role of inflammation in both cancer symptoms like pain as well as the tumor viability itself. This is a very small study with 141 patients with advanced cancer who are getting standard cancer treatments and standard palliative care. And it was a subset of a larger study. They tried to just assess whether CBD oil had any anti-inflammatory effects with the outcome looking at the inflammatory marker CRP compared to placebo at 14 and 28 days, a very short study. In this one, they didn't find any difference in those receiving CBD oil versus placebo in terms of their CRP levels over time, and they could not conclude that CBD tech necessarily reduces inflammation. But this is a very small, short study, and basically they concluded more research is needed. Corey in 2022 tried to look at really the microbiologic mechanisms of cannabinoids and asked an important question in terms of its role in cancer treatment. They found kind of in the lab that cannabinoids like THC and CBD do have immunosuppressive properties, and they play a role in immune cell death, suppressing pro-inflammatory cytokine production, and inhibiting immune cell activation. And so there's a big role in, potentially symptom management where inflammation can be a big part of causing things like pain. But it is unknown whether that anti-inflammatory effect would also interfere with immunotherapy, which is a major part of cancer therapy these days, or whether it would potentially increase infection risk. So that they're posing out there, more research definitely needs to be done, especially with the way that cancer is being treated in the current setting. This one study in 2023 tried to address that question. They looked both at preclinical mice studies, which in this one did not seem to show any reduction in efficacy of an anti-PD-1 treatment in mice that also were given cannabinoid products. And then they also did a component of a retrospective review of 200 metastatic non-small cell lung cancer patients who were receiving first-line pembrolizumab, one of the very commonly used immunotherapies. About half those patients were given a medical cannabis license in the first month of treatment, and they tried to look to see whether there were any difference in time to disease progression between those who had a cannabis certification versus those who did not. I think one big caveat is they could not confirm whether people consumed the cannabis. They got a license does not mean they actually took in any cannabis products and at what doses. So it's not really a very strong study at all at this time, and definitely more research is needed for that. In terms of cannabinoids, specifically in the geriatric population, this review in 2020 tried to look at the very few existing studies in this realm. There were 8 randomized controlled trials. They tried to look at specifically cannabis and its role in dementias, Parkinson's disease, COPD, and its role in appetite. Very small studies, even pools, there were only 117 participants. They did not find any strong evidence of efficacy in dementia-related neuropsychiatric symptoms. There were definitely dose-dependent side effects that were present and basically insufficient evidence to make recommendations. So, overall, I think it's pretty clear currently there's not a lot of strong evidence out there. So, this review by McCallum kind of summarizes pretty well how we approach then the use of medical cannabis for our palliative care patient population. If you are going to consider initiating this, you definitely want to have the conversation with your patient as with any other medication that we use. You want to screen for any contraindications and risks, screen for drug interactions, consider what might be a safe route of administration. If you're going to do this, recommending starting with the lowest dose and slowly titrating up, and then being able to monitor over time response to therapy if the patient decides to start that. And the overall takeaway is it's really important to weigh the risks and benefits of medical cannabis for your individual patient, and really to consider standard available treatments first, given the lack of strong evidence at this time. We're going to go through some of the legal and practical issues regarding medical cannabis, as that impacts kind of how one will actually practice in your state if it is an available option. So currently, federal versus state laws, cannabis is still a Schedule I substance under federal law. So most of the medical cannabis is regulated state by state and not in a federal setting. And this has implications in that basically, other than 3 specific medications currently approved by the FDA, everything else is not actually FDA managed. It is illegal to transport cannabis products across state lines, so it has implications if you're seeing patients from out of state who may be traveling between states or have questions about whether you can actually certify if they live out of state to where you're practicing. Inpatient pharmacies cannot label, store, or handle medical cannabis products, and it is not. Most of the medical cannabis is not covered by insurance, so costs are cash and out of pocket. So that's another factor to consider for your patient in terms of access. And then even the laws regarding medical cannabis between states are extremely variable. This review had a good diagram showing that across the country there's a wide variability in whether states have both adults and medical use programs, one or the other, or no programs at all. So important to know what's happening in your state or the other surrounding states where you see a lot of your patients. Just briefly on the few FDA-approved cannabinoid medications. These are mostly, they're not full plant derivatives. They're really specified to lab created products. One of the most common ones is dronabinol, which is basically a synthetic THC. It is currently FDA approved for the indications of HIV, anorexia, and cachexia, as well as chemo-induced nausea and vomiting. Nabilone is another one. It's a synthetic compound that's very similar to THC, and it's also indicated for chemo-induced nausea and vomiting. And then more recently, there was Epidiolex, which is a purified CBD product that is used in refractory or severe epileptic syndromes, and it's mostly used in the pediatric setting at this time. So other than those 3 FDA-approved products, everything else that is consistent of medical cannabis basically is not regulated by the FDA, and it's variable state to state. So just looking at an example of New York State, each state will have different regulations, but in New York, if things are to be sold under medical cannabis, they have to meet some specific manufacturing requirements, and they have to clearly label the ratios of THC to CBD, as well as the doses in those. New York State itself does not, include things that are edible, so like food-based products or smoked cannabis as medical cannabis. Those may be recreational products, but they're not medical products. Any ingested product itself, each unit cannot contain more than 10 milligrams of THC in 1 unit. And there are various formulations that are available that can be included in medical cannabis, and they can include things like tinctures and sprays, metered oil preparations that can be used for vaping, grounds or whole flower for vaping, and then various capsules, tablets, or chewable lozenges, as well as some topical products. And things can look very variable depending on the manufacturer and the dispensaries in which they sell to. So quick note on the routes of administration and whether vaping is actually safer than smoking. I think there's not enough known at this point. Vaping can be used with oils and concentrates or whole flower. I think one of the concerns is oils that have preservatives and other additives when vaped and burned could cause potential lung irritation in that heating process that's required for vaping. Many years ago, there was a high finding of people who were vaping oils that were not necessarily regulated products, and there was a risk of vaping-induced lung injury. So, in the medical setting, unless we don't have strong evidence, there's a risk of lung injury. Most of the time, would not recommend inhaled products given its uncertain health risks. Of note, though, based on the pharmacology, it's important to at least know that there are differences in peak effect for different formulations. So for inhaled, onset of action is relatively quick, could be within minutes, peak in 30 minutes, and it lasts, range of 2 to 4 hours. Any oral mucosal absorption of things like tinctures or spray is also pretty fast onset, 15 to 30 minutes, and it can last, 3 to 4 hours. Ingested, like any other oral medication, will be a little slower, so it can take 30 minutes to an hour to actually have onset of action. That one, also more variable, could last longer, like 4 to 8 hours. So important when you're talking to your patients about the products that they may be using, kind of being careful not to stack doses so that you can have a high risk of side effects. Just looking specifically at, again, New York State example of the laws. In New York State itself, the medical cannabis program was implemented in 2016, and then there have been updates to the law, more specifically the Marijuana Regulation and Taxation Act in 2021, that also legalized adult use recreational cannabis in New York State and kind of revamped the Office of of Cannabis Management to oversee all the regulations related to medical, adult use, and like hemp programs in the state. In terms of the medical cannabis program specifically, it actually expanded eligibility criteria. So the qualifying diagnoses were broader, and you didn't really have to, demonstrate that there was a concurrent complicating condition. Really, you just had to have one of the qualifying diagnoses to be able to have your patient be certified. And it basically expanded providers' ability to just use their discretion to certify patients for any conditions that, as long as they deem they may have a benefit from trying medical cannabis as either a primary or adjunct therapy for symptom management. And it expanded the role for any provider basically who can prescribe controlled substances to be able to have an ability to get certified as a provider. So the certification process in New York looks like this. The provider, whether a physician, NP, or PA, first has to take a approved online certification course, and then they submit that documentation to the Department of Health, and then they can register themselves on the site that we use to do the certification. And you can list yourself publicly as a provider who's able to do medical cannabis certification. In the patient setting, when you're in clinic, you first do have to do the usual for controlled substances. You check iStop, which is our prescription monitoring program. You do the counseling with the patient, risks and benefits. There is a health commerce site, which is basically the website where you will do the certification. It's actually relatively simple. You input the relevant information, patient demographics, patient ID numbers, and their qualifying diagnosis, and whether you have recommendations for the pharmacist at the dispensary. And then you print the certification for the patient, and then the patient themselves, they can register themselves similarly to the Department of Health, and they basically can bring that certification with a valid ID to their local dispensary, and there they will talk to the local dispensary pharmacist really about the products in detail. So unlike other medications, you are not necessarily prescribing a specific dose or product. You are kind of counseling and ensuring that you've evaluated benefits outweigh risks for your patient to try medical cannabis products. They go to the dispensary, they do the counseling and talk about the products with the pharmacist, and then they can purchase the products there. So you're really doing a more of a counseling type role in this process. Just a note specifically on the Mount Sinai policies, as an example. Inpatient, because the pharmacy, hospital pharmacies cannot handle or manage any cannabis products. If someone is certified in New York State, and if they have purchased valid products at a New York State dispensary and they've brought it to the hospital, only the patient or a family or security can handle the products. A physician who is managing the patient inpatient at their own discretion, they can place an order for the patient to use their own medical cannabis product if it's indicated, and then the patient has to self-administer it. It's not administered by nursing staff. It's a very cumbersome process. A lot of times it's just not done. And often in the acute setting, there's less of an acute indication to be continuing the medical cannabis products necessarily. No smoked or vape products are allowed inside the hospital. And often inpatient providers are not the ones who would be counseling specifically or doing any initial certifications. So most of that happens in the outpatient setting. And in which case, for our department, you want to make sure you've done a full assessment, risks and benefits, counseling with the patient, assess contraindications, and often you would want to have used standard treatments first, given the evidence for those. And most of the indications for our palliative care department in providing certification would be specifically regarding pain related to serious illness, refractory nausea, vomiting, or things like anorexia. So the important thing is consult your local state and institutional policies to see how it would impact your practice specifically. So we're going to go to case and questions for the remainder of this talk. Case 1. So Mr. Smith is a 67-year-old man. He has a long-standing history of peripheral neuropathy in the past, and definitely worsened after he received carbotaxol chemotherapy for esophageal cancer. His cancer was resected, his neuropathy kind of improved to his baseline, but then later on he developed recurrence and had to get additional chemotherapy as well as radiation. At that time, his neuropathy worsened significantly, and he's had multiple medication adjustments. He has to remain on chemotherapy every 3 weeks. And over the years, there were attempts to kind of minimize opioids and using other adjuncts as much as possible. But by the time he's seen in clinic, he still has severe peripheral neuropathic pain. Looking at the medications that have been tried in the past, there's gabapentin, pregabalin, so gabapentinoids are some of the initial neuropathic pain agents, as well as SNRIs like duloxetine, venlafaxine, TCA like a nortriptyline. He's also tried topical creams to help with it. At this point, though, Mr. Smith remains on both a long-acting OxyContin 40 milligrams every 12 hours and a breakthrough oxycodone 10 milligrams as needed, as well as duloxetine and pregabalin, and still has severe symptoms. The question is, if he's in clinic with you, as a provider, would you certify him for medical cannabis? And I think in this case, you would obviously also talk to him about any major contraindications, make sure he doesn't have active heart disease, no high-risk psychiatric symptoms. And if not, he really has tried some of the, definitely all the first, second line treatments for his neuropathy and still has significantly bothersome symptoms. It is definitely, worth a try and seeing if medical cannabis will provide any additional benefit for his pain. Obviously, then, counsel on the fact that it may or may not be effective, extremely variable results between patients. And then, starting low, monitoring over time and deciding whether this is something that's beneficial as a continued therapy or not for Mr. Smith while you continue all his other standard medications. Case 2, Miss Robb, an 82-year-old woman with unresectable pancreatic cancer and moderate to severe dementia. She's on gemcitabine chemotherapy. 3 months ago, she was 119 pounds, her BMI was 20. Today, she is 105 pounds and her BMI is slightly lower at 18.7. She's with her daughter, who is concerned about the weight loss and asks for medical cannabis. What do you do as a provider? Weight loss, appetite are very common reasons that patients and families will ask about medical cannabis. I think it's, again, weighing risks and benefits. So in this case, we're talking about a geriatric patient. She has cancer, but she also has severe, moderate dementia. You want to look at her, weight loss. How significant is it? She's definitely lost a good amount of weight. Has she been tried on standard therapies? Is she following a nutritionist? Are there any other medications that might, be a first line to try with lower risk of side effects of dizziness, confusion, things like that are, even more susceptible in an elderly patient? So I think that would be the counseling to be done with the patient and her family, that it may be too early at this time to go straight to medical cannabis. I think there's some standard therapies and additional supports that can be tried and to monitor. And then really, if she is to consider trying medical cannabis, you would do, very close monitoring, counseling of potential side effects. And if there are any really undesirable side effects, it would not be worth the risk of, using medical cannabis, which again, may have very variable or even not necessarily a benefit for cancer-related cachexia. Conclusion and some CME questions. So basic take-home points. The cannabinoid physiologic action on the CBD receptors in the body is responsible for both side effects and the potential therapeutic effects of cannabis products. And the important thing is it's kind of two sides of a coin. You really want to weigh risks and benefits of your individual patient. There's a lot of increasing research, but currently there's still insufficient data to really demonstrate strongly the safety and efficacy of medical cannabis as, especially compared to standard treatments, even in the palliative care population. And so there's insufficient evidence to recommend it as a first line. Most often than not, you would use it as an adjunct after careful counseling. And then it is important to understand the local policies and available products when you're counseling patients in your state. CME question 1, The data for the use of medical cannabis in the palliative care population, A, shows a trend towards improvement in symptoms, although only sometimes statistically significant. B, demonstrates a high prevalence of adverse effects. C, is limited in terms of overall study quality. Or D, all of the above. Right answer is D, all of the above. CME question 2. Medical cannabis A is broadly approved for use by the FDA. B has been proven to be universally beneficial for all palliative care patients. C may be helpful because of the properties of THC. Or D has no side effects. The correct answer is C. So that concludes the talk. The remainder will just be some references that you can look at in your own time. Thank you.